Join us this new year for new conversations at the Commonwealth Club.
Hello, and welcome to today's virtual Commonwealth Club event. My name is DJ Patil. I'm the former U.S. Chief Data Scientist and member of the Commonwealth Club Board of Governors. It is my pleasure to introduce Bill Gates, co-chair of the Bill and Melinda Gates Foundation and author of his new latest book, How to Prevent the Next Pandemic. Bill has spent more than 20 years working on global health and development issues, including pandemic prevention, disease eradication, and so much more. In his new book, he really lays out what the world should have learned and what we are continuing to learn about COVID-19, and really what can be done to ward off another disaster. So we're going to be covering a huge amount in the next hour. I'm thrilled that you're joining us here. So please submit your questions online at the text to chat feature on YouTube. And of course, you can follow Bill on Twitter at Bill Gates. You can follow me at dpatil, D-P-A-T-I-L, and the Commonwealth Club at CW Club. And you can also find all of us on LinkedIn. So Bill, let me first start by asking you, well, I'm almost like, we're in this moment of the pandemic, which is almost interesting to take a step back and reflect where we are right now, because we're 886 days in, that's 2.4 years. Since the initial discovery in Wuhan, we've had 6.26 million deaths worldwide, 1 million dead here just in the United States, and probably a drastic undercount. COVID has moved to the number 3 cause of death here in the United States, just behind heart disease and cancer. In the US, 200,000 kids are without at least one of their caregivers or parents. We've had the worst economic impact since World War II. We've seen spike after spike of variants. Congress is literally stuck debating about COVID right now. And we're just beginning to start seeing the impact of long COVID. And yet we're still in the beginning, we're still in this pandemic, not the next pandemic. And so, the fundamental question is, why write about the next pandemic when we're still trying to just meander through this one?
Well, you're absolutely right that this pandemic remains a real problem and some uncertainty about what new variants there will be. Our science of understanding variants is actually pretty weak. And so although we don't think there'll be something a lot worse, we do have ongoing infection. I tested positive last week myself, even though I had my 4th vaccine, and luckily I didn't have a very bad case. The key is that things that only happen rarely, we have a hard time getting ready for. It's just easy to take the personnel that's supposed to be standing by and have them work on other problems. And so the CDC, which is an amazing organization, didn't keep much full-time work on pandemics. And so the idea of how do you scale up diagnostics? How do you reach out to the commercial PCR providers and, get that so that samples are being processed immediately, no backlog, and a, government website that makes sure the right people are being tested. We just weren't ready. And so we bungled that key first period. Now it'd be good to reflect and make what I consider actually quite modest investments in global surveillance, in US particular capabilities, and then an R&D agenda to give us even better tools than we ended up with this time. So, my book is fairly upbeat about, yes, this was a tragedy, but there was some good innovation that we can build on so that in the future, when you have outbreaks, you respond quickly and you try to prevent it from going global, which is when we use the word pandemic.
I think one of the powerful things for me, the way you started the book is actually about talking about firefighters and how our strategy and thinking, I didn't realize how far back firefighting goes. Maybe you could take a moment and sort of walk people through that part? Because I think it really helps frame how to think about risk.
Yeah, so firefighting is the analogy that I think most people understand because they see the exit signs, they know about fire drills, there's a fire department, there's fire hydrants. I was amazed that there's 300,000 full-time firefighters in the US. Now with fire, you have lots of small ones and thankfully now very few big ones. With pandemics coming into rich countries, you have very few small ones. You'll have a lot out in developing countries, but infectious disease isn't, all that prevalent here. And so these respiratory infections that spread very quickly, they don't come in to say the US very often. So it's easy to forget that. The firefighting used to be even a bigger deal because you had cities that were more flammable. And so it was in 6 CE that the Roman emperor decided he would have a bucket brigade. And that was well organized. Then throughout history, you have people like Ben Franklin, who was very big on, organizing the fire department and making sure people are ready. And so fire deaths today are actually pretty small. And that's because we're vigilant. I used to use the analogy of how we prepare for war, but things like war games are very abstract to people. They don't realize how deep all that is. Fire is the one where they, have a personal sense, and the investment we need to be ready is way less than we spend on that fire prevention system.
Mm-hmm. Well, in particular, one of the things that we'll get to is actually that it's not weird to drill for preparing a fire. We do fire drills all the time. We have fire departments practice. And so we'll get into that in a little bit. But, I'm wondering, at the landscape and the view that you've had, why has it been so hard for us to get our act together? Just in the last decade, we've seen Ebola, SARS, MERS. President Obama called out this as one of the singular issues. We've called it out for more than a decade on bioterrorism. The call for a national disease forecasting center. In 2015, you gave a TED talk that has, I think, over 40 million views on it. So people clearly are getting it. Why aren't we better prepared as you've looked across this issue?
Yeah, sadly, 90% of those views are after the pandemic started. So, the good case would have been if people have thought, what a weird thing that, I predicted in infectious disease and then it never came along. The ideal would have been that my warnings, and as you said, many other people, anybody who works in infectious disease or goes back and looks at the history, you do worry about this, even if you're not including bioterrorism, which is a hard to measure but significant risk, where you have to do even better surveillance than for naturally caused infections. It's a superset. You have to do everything that you would do for natural and then even a little bit more. But, no one felt it was entirely their responsibility. And even a question like, okay, who should have been talking to the PCR companies and getting that ready? CDC didn't think of that as their job. They have these labs, but very small labs that are really good at Salmonella, E. coli type outbreaks, but not where you have to diagnose the entire country more than once a month. And so we see a lot of different results where people got that diagnostic capability going quickly and coupled it with quarantine policies.
Well, let's go with that aspect of CDC, because it's an institution that has been set up primarily to prevent these diseases. Yet, as you pointed out, we've had this incredible left hand doesn't know what the right hand is doing, this fracturing across different parts of the ecosystem, flip-flopping on mandates of masks, challenges with, I think there's a lot of frustration even with people saying, who owns this? Is it CDC or FDA right now? We're still waiting, even though the data has all been submitted for child, 5 and under vaccine. So, in the US, versus other countries, one of the things that you call for is basically a pandemic czar. Like what's your takeaway and set of recommendations for what we can do to, for lack of a better term, refactor for those that are not technology, get our organizations in order so that we can get ready for this?
Well, the US, has incredible groups. The CDC, which is responsible for the smallpox eradication, that was completed in 1980. CDC is a huge partner of the Gates Foundation in polio eradication that we're near finishing. And CDC has a lot of things that they just do an amazing job on, but they did not keep a dedicated team that was practicing on pandemics. Their budgets were tight. There's a lot of pressing needs. People expected the US to have the least deaths per capita. And yet, we see that we are about as high as anyone. There's hardly anyone who has more deaths per capita than we do. That's partly age structure. It's partly the prevalence of the comorbidities like diabetes and obesity. But we did not distinguish ourselves despite all those predictions that we would. And so, it's worth going back through and saying, okay, who should organize trials for interventions? FDA is sort of the judge of trials, but we didn't have a clear sense of, okay, how do you get, take blood plasma or, some of the drugs that were rumored to work, did we actually rule them out or in as quickly as we should? And so it didn't come together. The cracks between, FDA versus CDC versus NIH, we had that problem. Other governments, don't have those groups with the deep expertise, partly because the world has a reliance on the US. When it comes to medical research, the US funds over half of all that gets done. Epidemiology, CDC and others, a lot of expectation there. And so we can look at, the exemplars, who did particularly well, who did particularly poorly. And of course, you have to adjust that now that we understand the risk factors. You have to adjust that for the age structure of the population to try and say, well, what are the lessons out of this pandemic, both things not to do and things that we should do?
Mm-hmm. What do you think that we've taken a black eye because of this in the view of the world as how they look at us in our abilities to rely on, basically CDC being the gold standard, as you pointed out?
Well, I think the black eye is more that we withdrew from the WHO in the middle of a global pandemic. So the one organization which has great capabilities, nowhere near perfect, but an organization, our foundation, funds for a lot of things, also super good on the polio work. The US chose not to be involved in global cooperation, and the money for global cooperation got sequestered under that administration. So the embarrassing thing was that we didn't, when you have a problem, you expect people to come together collectively, and the US really looked very badly in that respect. Some of the things that CDC didn't do, most countries didn't do that well. So, Australia, New Zealand, Taiwan, Japan, South Korea, it's mostly Asian examples, even though there are more travelers from China to those countries than there are to Europe or the US. You don't have many positive outliers in Americas or Europe as you do in Asia.
What did they do? And I know you get into this definitely later in the book. What did they do that differentiated them or have them ready to? They got, especially in this first front of the pandemic. I think there's a lot of people who kind of look and say, "Oh, was it just shutdowns or other things that allowed them to get ahead where we failed?"
Yeah, so in the US, we didn't get diagnostic capacity, and we were only testing people who traveled to Asia The first non-traveler case was actually detected by a Seattle-based study that I was funding called the Seattle Flu Study, where we were looking at all respiratory pathogens. And even though our study protocol, didn't let us notify the patient, when we found a COVID case, the principal investigator decided to, speak up about that. And so we just wasted that first 100 days. Australia, partly because they had had a big scare with SARS-CoV-1, they got that their public health labs couldn't do it. And so their ability to get that PCR testing going and have a very high test rate. So people, would say, okay, I've got symptoms, or, I've been near somebody who has symptoms, and then having reasonable quarantine policies around that. Now, for them, that meant, blocking travelers going in and out of the country, even their own citizens, for a long period of time. But in the end, you have to say it was worth it because, 10% of our death rate, so for the US, that would mean 900,000 people who died would still be with us. Australia also got their vaccination rate up well above the US level. And so then they've been able to open up pretty much and now get their economy back going. They did have a little bit of a bump of some deaths right as they opened up, but they end up at that 10% level. So having had a little bit of a scare really was worth it for them. South Korea was scared by a MERS outbreak in a hospital they had, and so they actually got quite a bit of infection. They were about the only country where contact tracing let them get on top of it. And so they also have less than 10% of the deaths.
It's fascinating to me because, they got their scare. Your book is effectively a plan for what we should do because we've had this moment. And maybe this is a good time to shift gears a little bit into what the plan actually is, because there's a number of sections in there. Maybe to start with is maybe talk about this idea that you call the germ team. I believe the Global Environmental Disease Modeling.
Okay, Global Epidemic Response and Mobilization. And the book has just three things. We need to practice and get to the outbreak very quickly. That's where germ is the global piece of that, working with all the countries. Then there's an R&D agenda for better tools. And then finally, there's the idea that particularly in poor countries, the health system's underinvestment, by fixing that, which has a lot of equity benefits to help uplift those countries, that's also going to help give us the infrastructure for the early warning. So the most concrete thing by far, and actually, although it's $1 billion a year of cost, as I sort of pencil out, having something like 3,000 full-time people, that's the catch it early and help people run drills and actually go to the supervising body of the World Health Organization, the World Health Assembly, and give grades to countries. Have they been practicing? Are they ready to go? How much pressure should be on them because this is such a global problem? And a lot of people are talking about the finance piece of pandemics, but when a pandemic hits, the US government is good at writing checks, foundations are good at writing checks, we've spent over $2 billion. So the finance piece, there's something that can be done there, but it's really the expertise piece, having the data, reaching out to top modelers, flying in and catching that spread early. So I think the technical expertise, which some people think WHO already has. I make fun of the fact that in movies, there's a lot of WHO people who fly around and do great work. And sadly, the WHO budget just doesn't include that. So this would be like a 25% increase, $1 billion a year to the WHO, which rich countries, should want to fund, because even though it'll help the entire world, this for them is a pretty cheap insurance policy.
I always find it funny in the movies that they've got the plane waiting on the tarmac and they're going. And I tell them, like, when I flew for government, especially in this area of epidemiology, we were back at the plane, barely making our flights. Getting the equipment on board the plane was just, luckily if it didn't get lost in transit. And so maybe talk about also a little bit about, where does this, I think one of the things that we've seen is centralized versus decentralized in these efforts. And the efforts that have been highly centralized, in the US itself, the federal versus state versus city versus county, we see a fracturing there. We see the international aspects. And how would your model really help with that fractured systems that we have?
Yeah, so the global team, would be, based out of the regional offices of the WHO. So they'd be spread around the globe. The most likely risk of a new emergence is either Asia or Africa. The humans invading natural ecosystems that are changing because of climate, the degree to which people eat various exotic type animals, and you've got markets with those. That's mostly in Africa and Asia. And so, all the big outbreaks have come from one or the other. In Asia, you have mostly quite capable governments. And so they need to be, encouraged and given feedback on their preparation. China doesn't need people who know how to run diagnostics. They need to make sure the communications chain is getting this bad news out a little bit quicker. Now, they actually got it out fairly quick, but every day counts. And so going back through that is important. With Africa, in a few parts of Asia, like Yemen, you don't have enough government capacity there that on behalf of the world, you're going to be able to do it with local people. And so you really will have to have the germ team and, a set of volunteers that would, be on standby that can take this 3,000 and ramp it up to, 10 or 15,000. You'd have to have them willing to go in country and actually do hands-on work to make sure the diagnostics and quarantine are getting done in those countries, because otherwise it'll come out and get global pretty quickly.
For those of you that are following along, please make sure to start putting your questions in chat. I'm going to start getting to them in just a minute. Bill, maybe one of the things that also is in there that you talk about, especially, maybe there's no way to get around this, is like the politicization of this. All right. And we've seen this. It's very easy to look at it through the US, and we see it literally in everyone's backyard in some form or another. But internationally, we've seen this too. In particular, the one that I'm interested in is both at the front portion of the pandemic, we had issues like, China being not necessarily giving out the whole genomic, the samples early enough, or informing people about things. We've had, as Omicron was discovered, there's almost a penalization that happened to South Africa by them informing the world. And so how do we get to a place where, or what's your take on how do we cut through this with the greater objective of problem solving when we're confronted with the pandemic?
A lot of the activities like gathering the data, funding the R&D, those aren't that politicized. Where you get very political is where you're trying to get high compliance. So a shutdown, people wonder, is this a necessary thing? And of course, given the uncertainties, in some cases, that's a perfectly fair question. As we look back, maybe some of the school closures were longer than they should have been, now that we, understand more about the disease. humanity's got this problem that the next pandemic could be far more fatal than this one. We're ending up with like a 0.2% case fatality rate. Now, much higher as you get older or as you track with comorbidities. So actually, for somebody young without comorbidities, the death risk, even when you get infected, particularly if you've been vaccinated and boosted, is very low. So I don't have the magic solution to the polarization of society, but you'd think disease is one that, most of the issues, better R&D, better reporting, that we could come around on that. Even the best case out of China would have been maybe, a week to 2 weeks if they'd been perfect. And we can't assume that. So I think they were, actually very good. You can imagine in a low-income country it being far worse. I mean, Taiwan is kind of the extreme case. They reacted so quickly. Their death rate is like 1% of the other rich country death rate. And again, their connection to China is very strong. And they're not even official. They're not a member even of WHO. They're kind of on their own. So, the warning time wasn't that bad in this case. It's what you did once you had that data, or what you did even before the pandemic struck to be ready. Those are more differentiating than, the 1 or 2 weeks that we might have gained.
Mm-hmm. Well, I've kind of started with the glass is half is glass half empty kind of version, but I think switching to the glass half full version, because your book is really an optimistic book and sort of laying a pathway out. One of the parts that I think is remarkable and is underappreciated oftentimes is the speed at which we got vaccines. And you've been at the front of funding so much of the work around vaccines, especially in Africa and many places that people don't often think about, and where the impact is immediate, or we take those diseases for granted. Those are not issues for us. Maybe talk to us a little bit about, from your perspective, how you view vaccines, because you spent so much time on this.
Yeah, the one area where the U.S. Gets a very high grade, both in absolute and compared to anyone else, is the incredible funding for vaccine work. Initially through a group called BARDA that's under HHS, and then what became Operation Warp Speed, the US provided over $11 billion. And for the companies other than Pfizer, who did not take that money, but the other ones, that let them go full speed ahead and fund the science, the trials, even scaling up manufacturing at risk. And so a lot of the vaccines, Novavax, AstraZeneca, Johnson & Johnson, benefited from that. We weren't sure that how quickly we'd get a vaccine. After all, for HIV, malaria, TB, after decades of trying to do vaccines for those, which we will get, we don't have vaccines. Fortunately, most respiratory diseases, they have a protein that they use to latch on that the spike protein in this case provides a good target. And that spike protein was similar to SARS-CoV-1. So we had some understanding about exactly the configuration that would be immunogenic. Most of the vaccines worked. The mRNA are considered the gold standard, but the AstraZeneca, if you really measure it against what it turned out all the vaccines are best at, which is severe disease and death, it's a very, very good vaccine as well. So that's the incredible story, is that we got vaccines within a year. Within 2 years, we actually had so much vaccine that it's in oversupply. There's a lot that's spoiling because the demand hasn't taken up all those different vaccines that worked. Proving out a new platform, the mRNA, having that platform prove to be incredibly safe, with very few side effects. It's pretty miraculous, and that platform will be used for lots of diseases, not just infectious diseases. In fact, some of those companies, a lot of their value will come as they apply it to things like cancer. So the vaccine story is, full of heroes, full of great science, and, better than anybody could have expected.
And let's talk a little bit about also, while we've had this unbelievable breakthrough, we haven't had the distribution, or we've had distribution issues, both the inequities, particularly those that are underserved, both in the United States, predominantly the Black and brown Hispanic populations. But we've also seen this across the world, and there's been a lot of questions and debate about patents and other, different aspects. And one of the things that I was really well done in your book is talking about, well, how do you think about patents and what this does and doesn't do? And especially from the landscape that you've had trying to get these vaccines and therapeutics developed for Africa, maybe you could walk through a little bit of that.
Yeah, so the price of medicine is a super complex area. And there's certainly times where patents and the way they're handled affect that pricing in ways that hurt equity. In the case of this vaccine, that was not the limiting factor. That is, AstraZeneca promised to work on a nonprofit basis, and they went around the world encouraging all the factories that could make their vaccine, which is a lot more, because there were no mRNA factories. Pfizer and Moderna just had to build their own as fast as they could. The AstraZeneca, you could use pre-existing factories. And so our foundation gave $300 million to Serum, the world's highest volume vaccine manufacturer, and they took up the AstraZeneca design and now made 1.4 billion of that. So we did not get vaccines out to the low-income countries as quickly as we should have. It was inequitable. Disease, sadly, is inequitable every day. Like cancer treatments aren't there in those low-income countries. But here, we tried. We fell short on that. And so any country that was vaccinating young people before old people in every country got vaccination, that's inequitable. The US, India, Europe, a lot of young people were vaccinated before, South Africans, South Americans, or other parts of Africa got the high distribution out to the elderly. Now we're running into demand problems where, because of rumors, or some countries where the disease has not been that severe, there's tons of health problems and, kind of a lack of trust. In some countries, people have more protection because they got infected than, from the vaccine. We're lucky that Omicron, actually the case fatality rate of it is actually lower than all the other variants that came before.
Mm-hmm. Well, maybe what does it take? I'm going to get to some of the misinformation, disinformation a little bit later, but what does it take to get over the hump around these issues locally, especially, I imagine, definitely it's been there for polio. We've had this for so many other things, but especially with the Gates work dealing with infant mortality. How have you been able to get local areas to buy in?
Yeah, the ideal is to understand who people trust. In the case of polio, we had a period in the early 2000s where the rumors about the vaccine sterilizing women meant that we had about 30% of the houses that the house-to-house oral polio vaccine campaign would go to, they would refuse the vaccine. And there, it took us a couple of years, but by getting the Muslim religious leaders to visibly vaccinate their kids and explain that, this was beneficial and that you didn't want your kids to be at risk of being paralyzed, we were able to get rid of wild polio in Nigeria. It took us a while. It was hard. So you always want to look at those trust networks. As you said, some racial communities got behind on vaccination in the US, in a few cases by doing the right communication and finding the right communicators. Eventually the racial gap was closed, which, is a very good lesson. But it's, knowing who could convince someone. I say just, show people the hospital ward, and there was a period when the vaccines, were just out where, over 85% of the people were the unvaccinated. As the vaccine waned and people didn't get boosted, that went down a little bit. But, I always think the evidence is pretty clear, but that's naive. It's got to be mediated through someone that you look to and trust.
How do you think about it as you look across the United States? We have people who, you have these reports from physicians as patients are literally being intubated, they're still denying the existence of COVID.
Yeah, that's a wild thing. Most people are persuadable. Some people, have bought into, theories that it was made up for some reason or, a variety of things. Almost any crazy idea you can name, there's someone who's latched on to it. And of course, it spreads faster now than in the past because of digital media. But there's still a lot of persuadable people. We shouldn't, think that it's this black and white thing. There's still people who can be convinced. And also, the boosting levels, as we've seen, if the older you are, the quicker that protection wanes. And so boosting is an area we need to double down on as well.
Well, let's talk about boosting. How should we think about boosting and this debate that's going on right now of where do vaccines go from here?
Yeah, so, the vaccines we have today are amazingly effective against stopping severe disease and death. Some people's immune systems don't respond, but that's less than 1%. These are great vaccines. What we're seeing in the Israeli data and UK data show this, that the older you are, the quicker that protection wanes. And so you've got to be boosted. So there's two things about these vaccines that are not ideal. The duration, some vaccines, like the measles vaccines, you get, decades of protection. And so we've got to reformulate, but that'll take a long time. In the meantime, we're just going to have to encourage people to get boosted. The other thing that's not ideal, and the New York Times actually had a piece on one of the researchers we're funding to work on this today, is that the vaccine does not prevent you from getting infected. We hoped that it would, but in fact, with Omicron, and I'm an example of this, you can get infection, even after the fourth vaccine. Now, you tend not to have a severe case at all. What's happening is that as you acquire this disease, you're breathing in through your nose or mouth, and this upper respiratory area, the vaccines don't create many antibodies, secretory or other antibodies. The vaccines create a lot of the protection in your lungs, which that's fantastic, because that's where, if you're going to get super sick, it comes from what goes on primarily in your lungs. So there are new ideas about infection blocking, which if we had that, we're going to put a model out on this, you wouldn't see the spread that you see today. A lot of these transmission chains that sadly get to unvaccinated people or people where the vaccine didn't protect them, they're going through vaccinated people. So infection blocking would be a wonderful characteristic. And That's when the duration infection blocking, I think, that's on the 5 to 10 year time frame. And we need that, if we're going to use mRNA for HIV or TB, we need that duration to make it economic.
Yeah, one of the questions that's come in is the natural question that I think so many parents of young people have is, feels like the world has moved on, except they have kids who aren't vaccinated. And how should they think about this, especially as you develop a plan for the next pandemic where certain populations are left out because of either slowdowns in the regulatory process or, just it doesn't work for them.
Yeah, so, there's really good guidance from the CDC, as these vaccines get approved for younger ages. We're very lucky that young people, their risk is lower. It's not zero risk. About 5% of the cases or deaths from this have been people under 50. And, every one of those, for the US, that's 50,000. So, a lot of tragedies there. The fatigue about this pandemic is pretty unbelievable. I mean, 2 years, in the first 3 months, the compliance, even in most communities, was actually fairly good. Okay, the mask messages got a little confused, and but staying at home, shutting business down, that kind of thing. For 90 days, it's kind of novel, and people, for all they know, the fatality
people are
rate.
Banging pots and pans to cheerlead people. I mean, it was pretty amazing.
It really brought us together by and large. As you get out into this period of time where the damage is not just the disease, it's the depression of isolation, it's the missing education. The trade-offs are extremely difficult. And, I don't envy politicians, particularly now that the audience isn't paying that much attention. So keeping the awareness up, vaccinating and boosting, that's where the big win is. And some countries have gotten up as high as 90%. We're still right down about 70%. So that's pretty poor. And, with the elderly, you should be at like 99%. And there we're a little bit higher, but not above 80.
Let me blend a couple of questions together here, which is how, we're talking here now more than 2 years in, 880 plus days into the pandemic. When your plan, I think, is really ideal to not allow us to get this far in. And so the questions, I think, that a couple that come up is, could you get a little bit more into the specifics of things that would prevent us from getting to this point?
Yeah, the key idea is that even though, we're talking a lot about vaccines here, in the first 100 days, you won't have vaccines. And what you want to do in the first 100 days is stop it from becoming this gigantic number of cases, both in the first country it's in, but then, spreading out to other countries. And so we're looking at some new tools that would help with that, where you'd have a thing you would take that, independent of the pathogen, activates your immune system so that you're unlikely to get sick. But, just the conventional measures, those are, what we've got, and, what we need to make sure everybody's good at. Catching it in the first country, my book title is optimistic in saying that you'll have these outbreaks, but you'll get to them soon enough that it won't go global like this one did. And that's the first 100 days. And it's not a vaccine story. It's a communications, non-pharmaceutical interventions, and having lots of diagnostic machines out there. That is very exciting, that low-cost diagnostic machines that can be used for other diseases during normal years, we're going to get those out even in all of the primary healthcare system of Africa. So they would be able to take and say, okay, what respiratory disease do you have? And see, oh my goodness, this doesn't fit the normal pattern fairly quickly.
I'm so glad you brought up the surveillance, which often, sadly, it's called surveillance techniques, right? So it implies a sort of a negative thing, but this idea of surveillance diagnostics is you sample people all the time. One of the ones that I'm curious from your perspective is wastewater. And in particular, I still find it a little frustrating where I live is that I'm on the border of two counties. One county does wastewater, so I have good data from theirs. On another county, they won't publish it or don't have it. And how would this work from your perspective of a good disease surveillance network around the globe and sharing? Is it this germ entity that would bring it together? Is it WHO? How would this, what's your model?
Yeah, wastewater is kind of a miraculous thing. That was pioneered by the polio campaign, and we call it environmental surveillance. It's our best tool for seeing outbreaks, because a lot of kids with polio never develop any symptoms. And even if they do, that's, about a month later. And so we, in the countries we still have polio, which are Pakistan and Afghanistan, we do a lot of this sewage sampling, environmental surveillance. Now it's been extended to see typhoid, and amazingly, it sees COVID, and it sees it right away. You can even look at the variant mix in those samples. Now, in the future, most respiratory pathogens don't show up. What this does is not only attacks your lung, but it also gets into your gut as well. Amazingly, the sewage waste, none of the viruses in there appear to be infectious. So it's the best of both worlds. It's there as a clear signal, and it should be monitored, but it's not going to cause what's called oral fecal infection, which is how polio spreads, because the viruses in the sewage are overwhelmingly still infectious particles. So in countries with good sanitation, polio doesn't spread much. It's mostly where you still have weak sanitation. The overall looking at cases of people with fever and respiratory symptoms and gathering, the nasal sample and getting it off to say, okay, is this just the normal respiratory pathogens, which you might just be seeing an uptick because there's a lot of variation over time, or is it something new and novel? Fortunately, the cost of sequencing, where you can take those samples and actually literally look at the DNA, that's getting inexpensive. During this pandemic, there was money sent around both for variant tracking and just, to see the disease. So Africa was kind of in catch up, other than South Africa, because we had a lot of vaccine trials there, and they had, and they caught both beta early in the vaccine trials we funded. And then sadly, as you said, they also caught Omicron quite rapidly. And so that was tricky.
Mm-hmm. Well, how do we get, it's almost this issue of who's going to pay for this at the local level, right? Like, obviously, you funded so much of this in Africa to stand up these diagnostic centers so that they can actually catch things like Omicron and Delta. We don't have that really here in the United States, best I can, at least from my experience here. We've got a little bit around tuberculosis, we've got it around AIDS, but nothing else. So what do we need to do to get our own backyard in order?
Well, it'd be ideal that when you catch a respiratory disease, if we had antiviral drugs that could treat a lot of those, then you as a patient would be incented to deliver a sample and say, okay, do I have one of these where the drugs can reduce my infectiousness or my symptoms? And, I think we'll get to that point where that self-swab capability, not the one where you have to go hit your brain, that's going to be available, and then, those drugs will create a pattern. And then we'll be gathering that data and saying, wow, we're seeing a lot of flu over here. Let's make sure we sequence some of those and see, are we seeing a lot because it's a more virulent strain? What are we seeing in terms of hospitalization and that sequence? So the US could be a lot better on respiratory surveillance. And, I think we will pull that together.
Do you think the next pandemic will be respiratory, or should we be thinking about it in a different way, more like Ebola or something, completely different?
In terms of the rich countries, a overwhelming part of the risk is respiratory. Things like Ebola, where you're infectious once you're bedridden and you're not in a bus or a plane, they just don't spread that much. Now, you might have said, okay, sexually transmitted, how could that ever spread around the world? Well, the answer is that HIV has this latency period that you get infected and you don't have severe symptoms as an adult until 7 or 8 years later. So wildly, because of the latency, HIV is a pandemic, that got out into the entire world. But in terms of something that moves quickly, almost all the risk is respiratory transmission, where people on a plane who aren't touching each other can infect each other. And so the good news is you could see it in the air, you can see it in the lungs. It's human to human. Without human to human, you're just not that exposed to other species enough that it can, get up into the millions.
Mm-hmm. Great. One of the questions that's come in, actually, let me blend a couple of these also together, has really been about disinformation. No surprise, since we're here at the Commonwealth Club of San Francisco and Silicon Valley. And one of the things, maybe I'll ask it this way, as a technophile, which you are and you talk about in the book, really the role of social media, especially in this front end of the pandemic, where so much happened with the power of the network to take offense at, or somebody who was on debating about whether to take a vaccine or not and pushing them one way or the other. As reform and so many questions are on the table around social media, what's the responsibility of the social media platforms with regards to information, especially these kind of critical public health information?
Well, we certainly have to innovate there, and I wish I knew the exact answer. But what we saw were, people with a nice doctor title, saying hydroxychloroquine can save you, or, the vaccines are not effective at all, and a variety of things that reduced vaccine uptake. And, drawing the line between somebody saying, hey, I hear that at least in rare cases, these vaccines have side effects, which is absolutely true, to saying, hey, these vaccines are awful and nobody should go near them. What is the line where in a First Amendment country, you label, take down, rebut that, which, it's kind of exciting to click on, because it's like, wow, here's this very simple explanation that, this is all just about a few bad people, as opposed to complex biology with lots of uncertainty going along with it. That caught me by surprise. And, I would say, the crazy stuff got out there. The idea that, for example, I want to track people by putting 5G in the vaccine, that one is so far-fetched that, you have to kind of laugh at, why would I want to know the locations of various people? What am I going to do with that information? Then again, when it prevents people from protecting themselves and the people around them, then it's an awful thing.
I still can't get sometimes cell signal between San Francisco and Palo Alto driving, so let alone getting it in a vaccine is pretty far out there. But you're obviously bringing up these ideas to political leaders as you talk about what needs to be done and implement these ideas. twofold is, one is, what are you telling government leaders to do? How are you with your so much, not only personal capital, financial capital, but social capital doing to move the needle there? And then the part B of that is, are you having conversation with social media and other technology executives and asking similar questions, what they should be able to do or can do to help on these issues, both on social media or investments in other technological areas?
Yeah, in the social media case, people have to be creative about, okay, what specifically, would they have those companies do? They might, if you have good solutions, be willing to implement them or not. But how you draw the line of what gets blocked, and do you have a consensus around that? Particularly in the early days when things first come out, and sort of get established, it's very hard, given the volume involved. Should information about vaccines be treated in this very special way? I don't have the answer to that one. Getting the politicians engaged and saying, despite all the other things going on and the polarization, the war in Ukraine, inflation, we're still, recovering from this pandemic. Despite all that the voters expect them to draw on the experts and devote the reasonably modest amount of resources. And in the case of the new tools, things that will help us even when there's no pandemic, or the health system piece that'll help us. The only piece that's kind of dedicated is the funding for that germ team, which even if the US was paying, 30% of that, that's $300 million a year, which is, I hate to say it, kind of a rounding error in the US budget, and certainly compared to the pandemic related costs that we've borne. So,
or DOD's budget at $700 billion.
Yep. Although, now people are, it's a big budget.
Well, is there receptivity to this, or are people still struggling to? I mean, maybe the question it really is, what's it going to really take for us to get our act in order? I mean, obviously you've written the book, and that's kind of, so your kudos for putting out a plan. That's more than most people are doing. What do we need to do to galvanize to make this happen? Similarly, like, what can the Commonwealth Club be doing? These members, these people here, what can they be doing to contribute to making this a civil society, pulling these things together, making progress?
Yeah, well, clearly, a lot of medical research, the way that NIH has expanded over time and does great work, that's been bipartisan. A lot of new money for Alzheimer's, great work on cancer. And even though this isn't just academic research, which is where NIH money goes, some of this has to be more like ARPA-E or DARPA, where you're connecting in private sector companies because you need to know how to build vaccine factories and scale things up. So it's not identical to NIH money, but there are some models that we can follow to, take these R&D profiles and accelerate them. There's a lot of issues that inflame people and divide people. So making sure there's some bandwidth for pandemic preparedness, and not just the, hey, my president did better than your president, part of that, which, fine, there, some of those debates need to go on. But the R&D agenda is pretty clear to me. The global technical capacity, including the practice thing, that's pretty clear to me. So, I think despite all these distractions and political challenges, I do think that between the US and Europe and Japan, over the next 18 months, some type of consensus will be created here. This is not like climate change, where you're talking about, replacing huge parts of the physical economy, and therefore, it gets up into tens of trillions, so that's like 1,000 times bigger and needs all of society, engaged in those trade-offs. Here, it should become like fire. When's the last time people had to think about, oh, should we have more fire hydrants or, more firefighters? That's just at a, hey, I assume smart people who aren't even labeled in terms of their party are just saying, okay, maybe we can get by with a few less, or, based on forest fires, here we need in some areas a little bit more. So we need to get enough priority to get into the, day in, day out dedicated staff.
Yeah, compared to climate, one of the things I found surprising, at least from your plan, is cheap on the spectrum of things. Definitely when we price it against the impact we faced. And this quote I thought was really such a good reminder of it that you have in the book, which is, outbreaks are inevitable, but pandemics are optional. And so it kind of really framed it for me. We just have a couple minutes here, and I have two questions I want to get to. One is, what about the role of citizen scientists? We have these groups, the COVID tracking project. We've had all these volunteers that kind of jumped into things, US Digital Response. I could go on and on. There's so many people that kind of jumped in, especially the front end of the pandemic, still to this day. What's the role of technologists who have skills and, they're like the new volunteer fire bucket brigade?
Well, a lot of the deficits we have, like kids who didn't get enough education or, were kind of isolated, there's lots of room for mentoring and, highlighting that, we're going to take a long time before we solve those problems. Even research on long COVID, we need to gather a lot of data. So the data infrastructure, or the internet, even though it was part of spreading the crazy stuff, it also allowed people to come in and make real contributions, sometimes in terms of understanding the disease, what was going on, sometimes just working in the local community. These old folks' homes had to go into this very lockdown mode. And so, the need for volunteer help and things was super acute, or helping out the health workers. So yes, individual citizens contributed a lot during this. Some things like the data gathering, find it needs to be the scrubbing the data, that needs to be centralized, but the models don't need to be centralized. People, if they had a reasonably accurate set of data to draw on, which that should be pretty easy, then the creativity they brought to looking at it in different ways was quite fantastic. So for almost all our problems, including climate, thank goodness for citizen scientists. They're kind of trusted. They try lots of things. Some of them are dead ends, but collectively we have a way of finding the good ideas.
So last question is, for me, the thing that I was most optimistic sitting on the front lines of this pandemic, well, really, I should say the front lines were done by the healthcare workers, those of us in the policy roles or modeling. Second line was the rise of the citizen scientists answering the call of duty in this. And I want to end this with, what are you optimistic about?
Well, I always look to innovation in delivery, innovation in the tools. mRNA would have taken at least another 10 years to get established. So let's, tune it up to be better for COVID, but also for the diseases we still don't have vaccines. That's very promising. Getting more diagnostic capabilities out, I think that can help in the normal year in and year out disease burdens that we're dealing with. This move towards the quantified self. Well, that starts as a high-end thing, but eventually, tracking our health and our compliance, I think that's going to be very promised. So, digitization in health, whether it's, seeing your therapist remotely, or, just tracking how you compare to other people, I'm very upbeat. This was a tragedy, but it's shown where, we messed up. And, I do think we'll respond to that. It's, I love the tools work, a lot of which has already begun. I love the fact that people were forced a little bit to remember how inequitable health is. Africa have a 40 times higher chance of dying, and we need to take our wonderful science and some of our wealth and apply it against that. But it's not a topic we should avoid, because there is real promise in the innovation we can apply.
Well, we've reached the end of our time. Unfortunately, I got so many more questions. I'm sure you always get this. But our thanks to Bill Gates, author of How to Prevent the Next Pandemic. Thank you for joining us today. I encourage all of you to pick up a copy at your local bookstore. It's an excellent read. There's lots of really great stories and nuggets in there of how to think about this. You can ask more questions online. You can follow Bill on Twitter at Bill Gates, or me at DPATIL, DPatil. And of course, if you want to watch more programs or support the Commonwealth Club's effort in making both programs like this, which are virtual, or our in-person meetings, please visit commonwealthclub.org/online, as well as follow them online on Twitter at CW Club. I'm DJ Patil. Thank you, and see you next time.